It's lovely to spend time with you again today, and we're looking forward to our session with you. Again, just want to start the session by acknowledging the fact that a number of you have been through some terrible weather, climate disasters, particularly colleagues from Philippines and Vietnam in the last week or so. And I'm hoping that you and your families have got through it okay, but I'm sure there have been some terrible stories of very great difficulty and challenge. So we're just going to, yeah, wish the very best for you all at such difficult times in your countries and for many, many people. All right, well, I'm just going to continue with a opening karakia, as is our fashion, and then we'll commence our session today. Tukuna te wairua ki rere ki ngā taumata he ārahi a mātou mahi. Me tā mātou whai I ngā tikanga a rātou mā kia mau, kia ita, kia kore ai e ngāro, kia pupuri, kia whakamaua, kia tina humi e hui e tae ki e. Hold on to that which is good and secure it and come together is our thought for the day. So that's something that we all need to be thinking about, as supporting each other as a community that has been formed through this learning opportunity. And it's our hope that you will continue to connect with each other, not just within countries, but across borders as well, to build friendships and enduring connections and be supportive of each other in your work in health and public health generally. And so today we're going to continue on our journey of learning together. I always say it's a journey of learning together because I always learn new things. And so just because we're involved in the teaching doesn't mean we can't learn new information and understand the way we work and look at the world through different lenses. And that's the beauty of a class like this, which draws on people from, a large number of countries, many cultures, different faiths, different expressions. And so thank you for being so active in sharing in your small groups and in the chat. And we really love that engagement. And that's all very much part of good learning opportunity, isn't it? Anyway, so today we've got a normal sort of structure. We're going to have two sessions. And the first session, I'm going to hand it over soon to Monica, and she'll be finishing off our block on health promotion with some really interesting case studies, largely taken from New Zealand. And then after a short break, we're going to have Associate Professor Chris Payton, who's an expert in digital health and AI as it relates to health. And Chris has worked at Oxford University, the University of Auckland. He's worked in Africa, and he's an editor of a BMJ journal dedicated to digital health. So he's a very knowledgeable person and will be an excellent resource for you. And we've posted his slides up on the Canvas site, as we have with Monica's, and there are some good links on the readings and resources there to some key readings for you. If you can find the time to do those readings, that would be great. Okay, so I'm going to now hand over to Monica, and she's going to lead the next hour or two. And we'll break as usual for about 20 minutes in the middle, so you can get a stretch, go to the bathroom, have a cup of tea or something. Okay, Monica, thank you, and over to you.
Thank you, Chris. Kia ora everyone. So today I will continue the presentation about health promotion. I'm sharing my slides now. Okay. Okay, so we talked about health promotion on our last session, and now I will present case studies here in New Zealand related to health promotion program. And before I start, I'm sorry if it's a bit, there's another voice here. I hope it wouldn't disturb you. Before we start talking about the case, I want us to remember again about the Ottawa Charter. I just reread a pledge from the conference during the Ottawa Charter, and the thing that is really interesting, there are 3 points in the pledge of from the participants in the Ottawa Charter is to advocate clear political commitment to health and equity in all sectors, and also to respond to the health gap within and between societies by tackling inequities in health, and to recognize health and its maintenance as a major social investments and challenge. And I think the program that I will talk about today involve all of these things that already in the pledge. It's about responding to the health gap. It's also about commitment, not only in one sector, but in all sectors. And also to see health as a social investment, not only as a challenge, but also an investment, especially for the future. And before we talk about our program, which is the 1000 days program. And it's not only in New Zealand, we have a lot of other countries which have the 1000 days program. But before we jump into that program, we will learn some words in Maori or in Maori language, or we call it Te Reo Maori, because I send you a lot of links related to the 1000 days program, and you will see all these nouns that they use usually in Maori language, and we need to understand the meaning, and also it's one of the unique thing about English in New Zealand, because there's Maori terms. So when I first came here, it's a bit hard for me to read the news, because there's this Tereo Maori language. But over time I get used to it, and it's really interesting. There are 4 words that maybe you can find it in the links or in the source that I sent or that I uploaded in Canvas. The first one is peppy. Can you guess? Maybe you can put it in the chat. What is the meaning of peppy? I gave you a clue. Uh, baby, yes. Peppy means baby. So I hope I pronounce it right. Peppy means baby. And then the second one, tamariki. What is the meaning of tamariki? Can you guess? Tamariki. Child, yeah, children. It's tamariki. And the third one, can you guess what is the meaning? Family. But any of you can pronounce this word. So in Te Reo Maori, if you see W and H, you don't say wanau or hanau, but it's pronounced like F. I'm still practicing also, so maybe I'm wrong, but I usually heard people saying it fanau. So if you have W and H, it means it pronounced like F, so it's fanau. Fanau means family, and you can hear people talking about fanau all the time. It's like in every conversation, there's a lot of people talking about whānau. It's not only about family, that means your siblings, your parents, but also a family that is not only by blood, but by heart, by social connection. It's also whānau. And also the last one, mama. I think we all know what it means. Can you put it? Yes, mother. Okay, so next time you click on the link, maybe I send you some links related to this program. you know already, oh, if it's baby, then it's mean baby. Tamariki means children, and Fanao. I think there's a lot of the word Fanao in all of the sources, and you already know the meaning. Okay, thank you, everyone. Now we can jump to the program. So Te Whatuora, or the Health New Zealand, they have this very interesting 1,000 days program that all of us know. This program is about the first days, or the first 1,000 days of baby after the baby born until they are about like 2 years, right? So usually it's about how to raise a baby, how to keep a baby alive, how to keep someone alive. And I saw that in New Zealand there's some differences with other countries, especially in Asian countries. And one of the main things about this program in New Zealand, that Tevatu Ora mentioned, that we need to act early. So act early meant we don't only focus on the baby after they are born, but also not only about pregnancy, but also time before the conception. It's also important. So not only um, before baby is born, not only during pregnancy, but also they address issues before conception. So it's not only 1,000 days now, but it's like more than that. Okay. Yeah, oh, thank you. The Philippines and Myanmar also have this the same program. I think it's almost in every country we have this program, right? So that's why maybe we can compare this program with the one you have in your country. And this is what is also interesting to me, like the well-being of children depends on the adults' well-being. So I think New Zealand take it so seriously about this because actually because I was pregnant in New Zealand, and I I was helped by some student advisor, but then after I gave birth, this student advisor, she asked me to also help other PhD students who are pregnant, and then from them I can learn a lot more about what's happening during pregnancy in New Zealand. And then one of the things that is interesting to me is that in Asia, usually if something happened during the pregnancy to the baby, then we will act quick to see what is happening to the baby. But however, some of the students told me that she had this bleeding during her pregnancy, and then the thing that was happening is that she was hoping that she could get ultrasound, but the first thing that the GP and the midwife did was to check on the mothers, because they assume that if the mother is well, the mother is good, then it may be also that the child is also in a good condition. So that is the assumption here in New Zealand. And also the other thing about the first 1,000 days here in New Zealand is that we have the culture of Maori, and people here in New Zealand believe that the knowledge of Maori, of or Matauranga Maori, and other indigenous knowledge, like knowledge from people from the Pacific Island, it also have much to offer to Western science. So it's not only about knowledge from the Maoris, from the Western science, but indigenous knowledge is also will also give something to the Western science. And also to reverse we have intergenerational disadvantage, and a community focused solution, or something that is rooted from the culture, will help us to reverse this disadvantage. And also the last thing is that we can simplify complexity by focusing on what matters to Fanao. So we need to focus on what matters to the final, and also have relationship, trust in the relationship and process, and also collectively learning. So that's about the first 1,000 days. I'm sorry if my house is a bit noisy, but everything is okay. Okay, now I continue to the program. Okay, so there are 4 programs that is now being the focus here. So it's supporting communities, supporting system, and also transformation and leadership, and also about alcohol spectrum disorder during pregnancy and even pre-pregnancy, and also about the maternal well-being. So there's 4 different programs here that is being a big program for the focus. And the first one is about supporting communities and innovators. So I think I'm having a random day today. So can I have maybe 2 minutes break? But can you put it in your chat? Is there any innovation or something like funding that government give to any organization in your countries that support this program? If you have one, maybe you can put it on the chat. And I excuse myself, I need to
Monica,
2
you're
minutes
going to
break. Yeah.
sort that out. That's fine. You sort yourself out, and we'll organize the
Yeah.
feedback
I'm sorry.
while you go and do that.
That's part of the 1,000 days program. Okay. 2 minutes. Wait.
Getting quite a bit of noise from someone. Can we cut off the background noise if possible? If you just put your mic on mute, that would be great. Thank you. So I'm just going to read out some of the comments that have come back in response to what Monica's shared so far. I'll just put my camera back on. Oh, somebody's got a noisy background again. Can you put your microphone on mute, please, everybody? Okay, we'll just work through the chat. Thank you. Okay, so Prita has said, I think the idea of well-being in children depends on the adult's well-being is mind-blowing. We're in Indonesia. We also have many ranges of programs, but when we do a home visit to mother, we usually more focused on clinical checklist, not a psychosocial concern of the adults. Yeah, that's really true. It is pretty holistic, isn't it? That's a really good observation. Yeah, from Fon in Myanmar, UNICEF's working in coordination with the ministry and implementing partners there. And what else have we got? I think those are the main 2 comments. And Monica, you're back.
Yeah, sorry for the distraction.
No problem, no problem.
But
You're
yeah, I
having fun.
think I need to hold this one here.
So this is the
I'm
first 1,000
sorry.
days.
So yeah. Usually I hit him. Sorry. So usually I hit him in the bedroom. And usually it works, but I don't know why it's not working now.
Okay. Sorry, Monica, we've got a bit of background noise. And again, I'll just ask everybody turns their mic off while Monica's speaking, please. Thank you.
Okay, thank you. Okay, thank you. So thank you everyone for adding some of the yeah, from Philippines, from Myanmar. So what I was about to talk about, the supporting communities and innovators, if you saw in the website from Teva to Ora, you will see that there are a kind of opportunity. If you want your organization to support this program, then you can join, and maybe there's a procedure that you can do to get funded. So that's one of the thing that the government cannot act alone. They need some support from others. So yeah, it's the first thing. And the second is supporting system transformation. I have it in the next slide. So it's about service improvements, it's about guidance, and it's also about workforce plan, and also having an indicator. A lot of us can plan any kind of programs, but we need to have strong outcomes and indicators. And also that I found very interesting is the IT solution. So we are now living in this digital era, and we always need a solution related to the IT. And I think if you learn something related to IT in New Zealand, maybe you cannot also apply it in your country, because we have different kinds of problem with our, at least I know in Indonesia, Malaysia, and some country, we need to be creative with the IT solution, because not all people can have good internet access, but we still need a solution related to the technology that is tailored to every region. And also they have made the transformation in services for all the funnel. And also this is what one of the interesting thing is about bereavement. So when we talk about the 1000 days program, they don't only talk about the one that succeed, but also about people who lose, who has to deal with grief on their middle of their journey. So they don't only say about the one that succeed, but also the one that need support. And also there's a lot of maternity system changes, and it always need prototypes. It always needs something that we try first. It always need pilot and trial before we can apply all of that system changes. Okay, and next, wait.
We're getting some good feedback from the different countries about the different government programs and
Yeah,
collaborations with partners right across
yeah,
the ASEAN region. It seems to be a common moniker.
yeah,
So you've hit the nail on the head with a very popular framework for approaching
yeah.
maternal and child health.
Yeah. There's a lot of NGOs and also companies that mostly it's from NGO, right? From the
Yep.
UN. Yeah.
Government
That's
supports with budget often, and also nutrition focus, very strong
yeah,
focus on
nutrition
nutrition.
focus.
Mm.
Yeah. Yeah. There's a lot of support, and I think most of it are related to nutrition, right? Okay. And service capable. Oh, yeah. Okay, thank you. And the other program here in New Zealand that is, I think it's maybe it's not happening in your country because we have different focus. But here in New Zealand, fatal alcohol spectrum disorder is a concern that we need to address. And there's an education related to this. You can see the website. I already put it in Canvas. So there's education on how alcohol affects your baby, and also this. There are a lot of services. If you search in the website, it's related to maternal services. So if a mother is also having problem with alcohol consumption or even alcohol addiction, there's a lot of community support, including uh, a kind of rehabilitation where mother can also bring their baby. So it's a kind of both a maternity service but also a rehabilitation. And I try to find the picture of our videos, but I cannot find one. I found some in other countries, but not the one in New Zealand. And then I found out that they also have this kind of programs in Thailand. So I found one in Thailand. So it's pretty interesting that sorry, we have this program, this kind of program in Thailand, because I think there's also some alcohol related program. Probably not in New Zealand. Okay. Okay. Solve. So this was about the fetal alcohol spectrum
Can
disorder.
I just say a comment about the FASD? the fetal alcohol spectrum disorder. In New Zealand, we also have labeling on bottles of alcohol and cans of alcohol, which show a sort of a tiny, tiny little bit of labeling, but it shows a pregnant woman and has a message about drinking alcohol during pregnancy can harm the fetus. And so that's another form of health promotion, obviously, by trying to label and discourage, remind people if they're thinking about drinking alcohol during pregnancy.
Yeah.
So it's not just the programs, it's the policies that lead to things like packaging warnings and that sort of thing. But I can tell you it's taken about 20 years to get that warning label on alcohol, and it's a tough battle, and it's tiny, it's not big enough. So there's a lot more work to be done by people advocating for public health to try and get these messages across, because we think about 5% of pregnancies in New Zealand have some impact from alcohol consumption during the pregnancy, which is terrible because it potentially, has huge consequences for individuals with FASD and their whānau and community. Anyway,
Yeah.
that's all. Just putting that in there.
Thank you, Chris. 5% is a big number for me. I mean, it's 5 in every 100 babies. So that's a big number. And also, the level is very tiny. The warning is very tiny, and I also saw it in several Southeast Asian countries. We have that warning, but there's also it's some sort of it's a proof that we have policy related to it, but there's also need some more things to be done after the policy. So thank you, Chris. You can you all can see one of the sample of maternal services for people with alcohol issue, but maybe you won't see any like clear video related to it. So we come to the next program. It's the maternal well-being. Okay, this is what also interesting to me, that here in New Zealand, people focus on the well-being of the mother and also the father. And there's this website from depression.org.nz, and it's dedicated only for navigating parenthood, because navigating parenthood is also not an easy journey. And if you can see here, the focus of this maternal well-being program is related to fertility. So it's before the pregnancy and also during the pregnancy. And also there's a lot of issues after a baby is born. It's baby blues, depression, anxiety, and also traumatic birth experience. This is the focus of the program. I think there's a policy, and also there's a kind of regulation for midwife, GP, and other doctors to make sure that the mother is have the good condition, and they make sure that the well-being of the mother is already safe. So, and also the next thing is about the managing lack of sleep. We know that having babies mean that less sleep for the parents, and in New Zealand, people take the government take it more seriously, because if people, I think in some of Asian country, including in New Zealand, when we bring the baby to the doctors or the midwife, the first thing that they ask is usually is about the babies. But here in New Zealand, the first thing that they ask is about the mother. Are you okay? Are you sleeping well? How's the baby's sleeping? Do the baby like wake up every hours, something like that? So they make sure that the mother and also the father is in a good condition, and they also have some tricks, I say, to make sure that they also have some this assessment, creative way to assess whether there are some violence or abuse in the family. So they make sure that the mother is okay, and if the mother is okay, we can also make sure that the baby is also okay. And there's also a regulation related to social media and also losing a baby. So losing a baby is also a thing that maybe will create some traumatic for everyone. So it's once again, like I say, that they don't only talk about the thing that succeeds, that they don't only talk about babies that are healthy and they get enough nutrition, but also they also talk about people who lose a baby and how we can support them. And there's also a lot of information about how others can support, how friends, family can support people who's having a baby. So this is very interesting. And also there's a lot of information and support from the Plunket. Plunket is an institution with a lot of professional helping people to take care of their tamariki or their children. And also there's these toy libraries. So they really care also about the details, like buying toys for babies. It can add some financial burden for the families, and also it's also for the planet, because if we buy a lot of toys, then maybe there's a lot of rubbish in every house. So there's toy libraries that also help the parents to have a good better well-being by they don't need to spend a lot of money in toys. And this is I've already put some links related to some flyers and document. We have this one related to power to protect coping with a crying baby. And it helps parents how do they handle themselves with a crying baby. And also this is also an important thing related to how to put babies in car and how to have baby properly restrained in a car using car seat. Maybe it won't be any problem in big cities like Jakarta, Bangkok, or Vietnam, because we have a lot of traffic jam. So it's a lot of people don't restrain their babies in their car back in Jakarta and in Indonesia, because the car moves so slowly. But here in New Zealand, car moves so fast. So if there's an accident, it will be so serious. So it really need to we really need to be serious to restrain the uh, kid in a seat belt in a car seat. And also Blanket has this service that if you're not sure that you put the car seat right in your car, you can call them or you can go to one of their office and to make sure and to ask them whether you have installed your car seat properly. So it's not only about making recommendation for people to use the car seat, but they also have provide the service so to make sure that we all have installed this car seat. That one of the okay, Chris.
Oh, hi. Just to add to that, it's actually illegal not to have a
Yeah.
suitable child restraint in New Zealand. So the law helps support the behavior by enabling that action, by requiring people. But because they're quite expensive, Plunkett and other organizations have these car seats available that people can borrow for a period of time, and then they bring them back and they can be used for another family when they need it, because the car seats change as the child gets bigger as they get older. And so it becomes a big burden financially. So there's, in support of that help that they offer through child safety, they also have laws, but they also have ways of enabling people to comply or adhere to those laws so that nobody's disadvantaged or shouldn't be disadvantaged. That's all.
Okay.
Thanks.
Yeah. Thank you, Chris. Yes, there's a lot about it. So it's not only about recommendation, but also about the law. And yeah, I also remember that every family, when they take their baby back to their house, they need to have car seat with them. So even though I didn't have car, but I still need to put my baby in car seat before I go home, because at some point we need car seat also. And also there's a lot of postpartum program for babies. So there's this midwife visit, there's blanket and baby coffee club and other clubs. And also there's this personalized calendar for immunization. That is that I've already put the link on Canvas. So if you have baby, you can uh, just input your name and their birth date, and then they will show you on what day you need to have your immunization for the baby, and it's really cute. So I think it make you remember what you when you should go to the gym. And there's also some baby clubs, immunization. Sorry, baby coffee club is a place where mothers and fathers can meet in a certain place conducted by the council, and then they can chat, they can have free coffee for everyone, and they can just put their babies on the room and they can interact with each other. It's also help with their well-being, because sometimes they are very bored being at home for months. So going out and have social life is very important, and especially for migrants. I see a lot of other migrant friends who come to this coffee club, because yeah, we need to be supported socially. And there are a lot of other clubs for new babies. Some need to pay, but there are a lot of free facilities. Like for baby from 3 until 6 months, we can get free swimming classes, uh, only for a few months, but it's also help parents to help making more activities for the babies. So there's a lot of supportive program here. Okay. And before I continue, so that's all about the program. And I plan to have a discussion. Um, At first, I plan to have a main group discussion, but maybe we still have time for small group work. What do you think, Chris?
Yeah, I think there's some good feedback coming in on the chat about people's different experiences. And one thing we're talking about, that holistic approach to particularly maternal mental health and family well-being and the need for professional people, but countries are getting around the shortage of supply by training people working in primary care with basic skills to provide that support. So that's a way of coping within the available resources to provide family support when there are problems like postnatal depression, mild
Mm,
forms of, problems that GPs and practice primary health centre nurses can deliver those as alternatives. But usually it's good to have a professional psychologist somewhere who can oversee and train and monitor the delivery of those support programs by other health professionals is going as it should, or be there as
yeah,
a referral for someone who's like really seriously depressed and needs medication, that sort of thing. Mm.
yeah. Thank you. It's the question from Prita, right?
Yeah,
Yeah.
yeah.
Yep. Actually, I was that psychologist in the Puskesmas.
There we go.
So, yeah. But actually, from my it was like more than 10 years ago. So maybe the situation has changed. But in Indonesia, there's also this support for people who are already pregnant. But I think they don't provide specific service for mother who with baby blues or other traumatic birth experience. But yeah, that's a good place to start. But I don't think there's Here in New Zealand, I think for new parents with newborn, the service is the first is from the midwife and the GP, and then they can refer to another specialist. So yeah.
Monica, I'm a bit out of touch because my children are all grown up now, but we used to go to antenatal classes. So the fathers
Yeah.
and mother used to go along to some classes with them run by midwives, and they'd teach you some basic things because you knew nothing and it was terrifying to think about being a parent with a tiny child. And they'll teach you things like how to hold a baby properly, change the nappies, and all of that sort of thing. So did you have that experience when you were pregnant here in New Zealand? Did you have the opportunity to go to antenatal
No,
classes? And it'd be interesting to know if that sort of opportunity is available in other students' classes.
now that you've mentioned it, I didn't have specific classes, but we came to birth care. So what do we call it? It's like maternity
Oh, yeah.
facilities, yeah. So after we gave birth and discharged from the hospital, every mother have I think they are eligible for like 2 or 3 days in a maternity service. So it's not hospital, but it's a place for mothers to learn what to do with baby. So all the people who are there who support are midwives, and I learned how to like bathe the baby, and I learned what to do when the baby has hiccup, or even just like please check whether I just put the nappies right. So yeah, I think we have that kind of facility in Korea, I think, but I don't know in Southeast Asian country. I don't think we have it in Indonesia. But maybe if any of you have that facilities in your country, you can. Oh, in the Philippines. Okay, so it's also a program.
Yeah. So some countries have got very well developed programs like Philippines.
Yeah, yeah.
Um, that's just great. It sounds incredible. That investment in that first 1,000 days is such a great way for governments to guarantee, well, not guarantee, a way for governments to spend money wisely, because in ensuring that children are well nourished, cared for, free from infections, and the parents are supported, leads to healthy children who become productive citizens, et cetera, et cetera. So it's good economic policy as well, and social policy, and makes for happier families too, of course.
Yeah. Okay. Thank you, Chris. So, thank you, Nino and others who have responded in the chat. So, I think we can continue to our discussion in the main room. Yeah, we can continue the discussion in the main room. So, what do you think about this 1,000 days program in New Zealand? And maybe I want to ask specific about what do you think about the difference with your country related to the issue, or the feeding issue in your country? Because I've uh, I've presented some of the programs in New Zealand, and all these 4 programs are the official ones that they put it in their publication. This one. But what do you think about this program, and how do you compare it to your countries? So can you put it in the chat, or if anybody wants to unmute their mic and share their opinion, yeah, we will be happy to hear. Is there any difference? Because I think some people from Philippines and Indonesia have already talked about this also in the discussion when we talk about health communication. So I think some of you already know the answer. Anybody want to share?
Yes, Miss Monica.
Oh, Nina, okay.
Yeah,
Yes.
I think no, all of us are also helping our child to grow in its better way. But there are differences. Like I am amazed with the New Zealand in terms of the maternal well-being, because you focused on taking good care of the mothers. While we do that here, a difference is that you have the whole package of providing the necessities of a mother, particularly on the emotional side of the mother. And of course, it also includes having check on the experiences during birth and up to the mother is already already at a good phase. Now in the Philippines, though we have that, but after the delivery, after 3 days, they are advised to go home, especially if that's normal. And because of the many cases, especially of the pregnancies here in the Philippines, maybe we are limited in terms of the whole package that we can provide to our mothers. And also the populations is very high. It hinders in terms of the service packages that we are providing. And we are limiting, or we have limited supplies in terms of micronutrient, vitamin, iron, folic, and even iron that are given before the pregnancy. So I think that's the big difference. Though we have the same package of intervention, or we have the same goal of attaining for the reduced mortality and morbidity of our children and the pregnant women, but still no, you have that kind of very supportive environment in terms of the maternal and child package. Thank you.
Thank you so much, Nina. So, may I ask whether this program is applied only in some regions or it's also in the country? Because I think there's gaps in Philippines are also like Indonesia, right? Where there's some remote
Yes.
islands and there's some cities. So what do you say
Yeah,
about it?
Miss Monica and the whole team, this is implemented across different regions and over the rural areas. However, we cannot deny the fact of the gaps, particularly of the delivery of the quality services and the human power or the human resource that we have in the government.
Okay, thank you. Well, that's very great. It's very nice to hear that you already applied such a great program for newborns and also for the mothers and also about the nutrients here. And it's also one of the focus, right, related to the nutrition. Here in New Zealand, yeah, they focus also on the nutrition, but it's not I don't say it's not the main focus, but it's like assuming that if a mother already have a good well-being, then I think they know how to have good nutrition for herself. But if we don't talk about their well-being, we don't address their well-being, maybe it's very hard for them to decide how to have a good nutrition for herself and for her baby. So yeah, thank you, Nino, for a lot of input that you gave. Is there any other participant from maybe from other countries who want to share?
I am Hương.
Okay.
I want to share. Yes, I'm
Yeah.
Hương. I come from Vietnam. Yes. The first, I think this is 1,000 days program in New Zealand is essential and a very essential for family and baby. Can you listen? Can you hear me? I
Yeah, I
don't.
can hear you right.
Yes.
But if you could increase your volume a little, Hong, that would be
Oh,
helpful. Yeah, if you could increase the volume a little bit. Thank you.
Yes. Yes. I I think the New Zealand program driven by Health New Zealand is focused on the critical periods from conception until a child's second birthday. This program is comprehensive and deeply rooted in a cultural appropriate community focused book, especially for Maori family. In Vietnam, Vietnam also has a nationally recognized program focusing on the first 1,000 days of life, aimed at improving the health and nutrition status of pregnant women and child under 2. The similar results in Vietnam in the country is the 3,000-day window. Both countries recognize the period from conception to a child's second birthday as a critical window for long-term health, cognitive capacity, and physical growth, and focus on nutrition, improving maternal and child nutrition, especially reducing stunting and underweight rates in a primary goals in Vietnam and a major component of the goal 1,000 days of movement which New Zealand also aligns with. And key difference in New Zealand and in Vietnam 1,000. The first features primary approach. New Zealand first 1,000-day focus on cultural center and community led. In Vietnam, is the Vietnam program focus on health system center and the next social cultural focus. In Vietnam, focus on addressing the disparity, particularly between urban centers and remote mountainous ethnic minority regions. And the next indicators is for in Vietnam is for achieve specific national targets for reducing stunting and underweight rates, and the difference about deliver model. In Vietnam, focus on improving the available affordability and quality of health service, and strengthening the referral system. In summary, while both countries are committed to vital 1,000-day framework, the New Zealand program appears to play a more explicit and firm emphasis on indigenous knowledge, whereas the Vietnam program success is often credited to its strategic investment in a robust nationwide primary healthcare network to deliver cost, material, and child health service, especially targeting nutrition and material disparities in difficult to reach areas. Thank you for
Yeah.
listening.
Thank you, Huang. So, yeah, you also highlight that in New Zealand we focus on the cultural, and in Vietnam, the 1,000 days program involve nutrition from conception to child after second birthday, and also the focus is to reduce stunting and underweight. But I also saw some other comments from other fellow friends from Vietnam, and it's interesting to see, especially what Huong Tra said about the rates of obesity and early puberty are increasing in Vietnam. So yeah, it's a bit dilemma that in less than a decade we move from stunting to obesity, and it's mostly because of also the poor lifestyle related to the sedentary lifestyle, and also related to the processed food. There's a lot of processed food here in Asia and also maybe in the world. So yeah, thank you. So, and yeah, you mentioned that in New Zealand there are more cultural rooted, but Huong, do you know if there's the maybe the policy or the program in Vietnam also includes some of the indigenous knowledge, or yeah, any kind of culturally rooted knowledge from the culture in Vietnam?
Yes, I learned yesterday you teach about 1,000 day program in New Zealand, and then I am in Vietnam. It is maybe it's the same. It's the same focus. Meaning it's meaning 1,000 program in New Zealand and in Vietnam, but a little is different. Primary indicator maybe it's a different culture, and maybe it's a different culture in Vietnam and in New Zealand.
Okay, thank you for answer, and also for Wong Tra and also Hang Nguyen, who also support what Wong Nguyen says related to the program in Vietnam. Thank you so much. Yeah. Some programs are also the same here, like prioritizing breastfeedings, balance feedings, but there are also the different related to culture. Okay. And also there's this input from Nino. One of the feature in the Philippines is multi-sectoral approach, not only the health department, but also other entities like agriculture, social welfare, livelihood, and other relevant partners. Wow. Wow. I think what's the program in Philippines is really holistic, right? Does New Zealand do the same? I will talk about the other program after we discuss this, but yeah, we can save your question for later. Thank you, Nino. Okay, and back to the discussion. Is there any other participants who want to share about this program in their countries? We have Philippines and Vietnam. Do we have from other countries also? Or if you are also from Philippines and Vietnam, but want to add what your other friends have said, you are also it. Yeah. No.
Okay, good morning.
Oh, okay,
Monica.
Rina. Hi. So,
How are you doing? It's okay.
I'm good, but you lose your wings, right?
Okay, so now I'm just sharing because very beautiful question discussion with the main group here, and actually this one is the group that the difference between the 1,000 days program in New Zealand and is compared to Cambodia. So beautiful far away from each other, I think, because actually in Cambodia, you know, that in New Zealand we have the to get a primary goal of the healthcare is they can be achieve equitable. Yeah, but for the Cambodia here, we the primary goals that we offer the health promotion for the youth, maternal and child mortality and malnutrition through access to essential health and nutrition services. And the other one is that, you know, in Cambodia, the financial incentive and cash transfer for only for poor families and improve to access the basic health and nutrition services. And the other one is that Cambodia, you know, and based mostly on the uh, uh, donation to support for accessing to healthcare. And the last one is about for the Cambodia as well, the target intervention and social assistance to encourage use of the existing health infrastructure. If compared to the New Zealand, you know, and communities lead lens innovation and cultural integration and system reform and mental well-being to support So great already. Yeah, that is from my side, from Cambodia side. Yes, thank you, Monica.
Thank you, Rina. So you mentioned about cash transfer for poor families. That's very interesting. But is it a successful program? I mean, do they know how to use the cash in a wise way? I mean, they use it properly or not?
Yeah, actually, this one, Monica,
Mhm.
and the other one, and Professor. And actually, you know that according to the last 2 years, that the program for the 1,000 days program here offer for the mother pregnant, and especially for I think that for rural or some poor areas, that all those I might say many some of parents, yeah, I might say some of parents and some of mothers, they still limited to access the program. And the other one is that they could not understand about the program apps. That's why with the equity, I think that they still limited. Yes, that is from my side. And the other one is that even those not only from the NGO or INGO or from the government, and that also doctor and nurse and the health staff, they also to promote about this healthcare, but they still limited to access all these points. Yeah.
Thank you.
Anyhow, that example in my experience, as my point here, at my weekend, I always go to my hometown to promote the health care for the children and for the poor family, as well as near the Phnom Penh city in Cambodia. And I propose about my plan, and then I organize with the master of village and the other people that's still limited. So I also invite about psychologists as well as my friend who study related to nurse or doctor, or public health. So we are joining together to promote about healthcare promotion at my community, but not so worldwide yet, not so spread out generally yet, because we are busy as well from Monday to Friday actually. But anyhow, at the weekend for 1 month, we join 2 or 3 times per month to promote about this one, especially for the children, for health education at the primary school. Yeah, at my hometown. Yeah, thank you.
Wow, such a great work that you do, Rina. And
Yeah,
I
thank
mean,
you.
yeah, uh, we know that it's very different what's happening here in New Zealand and also in Southeast Asian country, because yeah, we have a lot of things going on in our countries. So yeah, it's nice to know that there's an example, but you don't have to achieve the same level, like perfectly the same thing with New Zealand, but at least you know, like it's like we're doing brainstorming. And also maybe from what I see, and also what Huong also mentioned, that in New Zealand they put more focus also about the culture. So maybe it could also inspire people from Southeast Asia, because we have like lots of culture, and it's really beautiful that we have this culture. So maybe we can also use this culture to help us educate people in our own countries. And I was asking you about the CAS program, because I think if there's some indicator of success in the CAS, the giving the CAS program, and then there's, or maybe even if it's only like some portion that is successful, it also a proof that you mentioned that there's not a lot of thing that you already did there, but if some of the program success, I think it's also because of support from the system, from also the other staff offices or also institutions. So we can start from small, but I think you start from big because you've already worked like I think it's for more than 40 hours a week, and then you add your weekends to that. Wow, that's great. That's very dedicated. Don't forget to take care of yourself also, right? Okay, thank you, Rina. Yeah. Okay.
Thank
Yeah,
you,
and then
Monica. Yeah.
yeah.
Monica,
Okay.
I
Yeah.
think Myanmar and Phone of Myanmar and Rizky also shared their
Ah.
thoughts from Indonesia, and Rizky from Indonesia and Phone from Myanmar in the chat.
Okay. Okay. From Rizky, thank you, Guy. There's also this 1,000 days, and usually it's from the nutrition outcomes to tackle stunting. But I think it's also like what's happening in Vietnam. Like it used to be the issue used to be the stunting, but now it's the obesity. Okay. Indonesian Program Center on Training Community Health Workers. Yes, we need to train more people because a lot of Southeast Asian countries we have high population. So and also there's limited good quality of human resources. I don't know in your country, but in Indonesia we have like less than 10% of people who already graduate from undergraduate degree. So less than 10% from 280 million people. So that's quite a challenge for all of us. So we need to train more people, more health worker, and to improve more access to nutrition and large scale campaigns. So in New Zealand, we only have 5 million people in the country. So I think it make it a bit more easier. And in big countries like in Indonesia, in Thailand, there's more challenge related to the population. And also delivering free school meals, although there's a lot of things to note about this program. Yeah, but there are strong growing policy coordination, but challenges persist, especially related to fragmentation, operation, monitoring, and local level adaptation. So I think it's also happening in countries like Indonesia and the Philippines, maybe because we have these gaps, and maybe like Malaysia, you have two different islands with two different characters. So what we apply here maybe wouldn't have create the same outcome with the other region. So okay, thank you, Rizky, and also Pohnpei. If any of you want to unmute, just unmute yourself and let me know. So Pohnpei from Myanmar, nutrition promotion program here also involve not only MOH, but also Ministry of Agriculture. Wow, that's interesting. So Ministry of Agriculture, Livestock and Irrigation, and Ministry of Education. Yes, we always need to involve Ministry of Education because like maybe I talked to you in water only school programs. It also involve Ministry of Education.
Yeah,
I
that's
think
sorry, Monica.
Chris, yeah.
That comment about the different ministries involved in nutrition promotion is a great example of the healthy public policy or health in all policies. Getting the different sectors working together with a common objective of improving child nutrition. So that's a really excellent example of health promotion work.
Yeah, because Ministry of Health cannot do it all. Yeah, sorry, Chris.
And I was just going to say, I've also popped in the chat if people are interested in following out more about fetal alcohol spectrum disorder, FASD, which is included in the New Zealand package, probably not in your country. And there's a little bit about the labeling specifications and so forth. And you can go on to a little link down the bottom on the next post I put there, where you can actually look at the specifications for the little display that has to go onto alcohol products, and it's tiny. It really is, given the size of the problem. In New Zealand, we have almost most of the tobacco package covered with warning label and graphic warning and no branding. But with alcohol, it's the other way around. So we've got a lot of work to do in public health to try and change that messaging that's coming up, because it's causing so much damage to families through alcohol exposure in pregnancy. It may not be the case you think in your country, but you may be surprised. I've done some work in Saudi Arabia, and there are big problems with alcohol misuse, even in a country with a very solid, religious background like that. So.
Yeah, you are right. There's also some alcohol-related problem in Indonesia, especially in maybe people from low socioeconomic background. They usually they create their own alcohol. I think there are some news related to this illegal alcohol that people made by themselves, and it's an issue in not only in Indonesia but also in some other countries. Like I think I heard in Laos or Vietnam also. So yeah, that's quite a challenge for all of us. Thank you, Chris. And yeah, this one from Diana. I think both New Zealand and Indonesia use the first 10,000 days concept to upstream public health, but they apply it differently based on their national priorities. New Zealand's program is a broad, holistic strategy. It focuses on the entire system, targeting complex. Yeah, okay. It's more complex issues, okay, like maternal mental well-being and social equality. Indonesia's program is deep targeting intervention focused on a specific national goal, stunting prevention. Its key upstream action is providing multiple micronutrients, not just to pregnant women, but to prospective brides. Okay, that's also proof that and also the same thing with New Zealand, that it's not only on pregnant women but also before the conception. In short, New Zealand approach is about system-wide well-being. Indonesia is precision strike on malnutrition before conception. Okay, thank you, Diana. Okay. We have from Indonesia, Myanmar, Vietnam, the Philippines. So any other participant wants to add? Or also about I'm interested with what Juan say that about the culture. Don't worry, that most immunization are with in the first 1,000 days. So it's also a disease prevention strategy. So there's a lot of things going on in the first 2 years of life, and it's very complicated. And yeah, quoting from Diana, in New Zealand, we already tackle the complex issue, but there's also a basic issues like nutrients and also immunization, mostly in Southeast Asian countries. Okay. Anybody want to add? If not, then maybe I will ask one more question. What do you think about in your country? Do you use like cultural perspective in your country? Because I know in New Zealand we put the perspective in Maori perspective and also other perspective. I think when I was looking for the source for this lecture, I found they also have this perspective from China and India. Also, they apply it here in New Zealand because we have a high population of migrants from China and India. So that's also a great way to create a program. But what about in your country? Because Southeast Asian country, we have a lot of different cultures, and I really like this one. Oh, sorry, I haven't. Here is this. Yeah. Yeah. Mata orang Maori and other indigenous knowledge have much to offer to Western science. So we can practice what we learn from the Western science, and that is good. But maybe there are some things from our culture that can add, or maybe it will create a balance and also a solution, because we cannot force people to do what they are not used to do. Okay, Nurul Ilma, most of the cultural practice here in my city are against medical science. Yeah, maybe. Yeah, there's a lot of things are against medical science. So my mother-in-law is here and she just knew that tea is not good for babies. She was like, huh, is it? But every children in Indonesia, we drink tea. So one of my first memory when I was like 3 or 4 years old, I drink tea. And that's why there's a lot of issues related to nutrition in Indonesia. So yeah. So yeah, maybe I agree with Nurul. Some of the cultural practice are against medical science, but I think there are also some things that can maybe become a complement of Western science. Pohnpei, Ministry of Social Welfare here is implementing maternal and child cash transfer. Okay, just the same with what Rina mentioned. As a component of National Social Protection, strategic fund to support the first 1,000 days program. Okay. Pohnpei, can you also maybe unmute your mic? And I'm really curious about this program. Is it a success there in Myanmar, or do you have any challenge applying this program?
Yes, this is actually not our component. Our program's component is actually implemented by Ministry of Social Welfare by the government itself. So I just have the information or that they are doing this program and don't have much other information. Yeah. So far, my understanding is they are doing this program not all over the country, but in the selected regions. I guess that maybe 4 regions of the Myanmar, where they choose the selected beneficiaries with their antenatal care records to register at their social welfare offices to have register in this system to have the cash support. Yeah.
Oh, anything you want to add? I thought you want to continue. No, thank you, Pohnpei. Yeah, so it's from the another ministry, and yeah, I think there's a lot of practice of give money or food for people in Southeast Asia, but the thing is we need to make sure that it is also supported by the system, and also that we have I think indicator or monitoring. I think we will talk about it tomorrow with Chris about monitoring, especially related to cash, because yeah, people maybe if they don't know how to use it, then it will be such a waste to waste cash. Okay, thank you, Pohnpei and Tantu. I think the current National Nutrition Program is not likely to reflect the diverse culture in Myanmar, but many ethnic health organization, that's interesting, are trying to include cultural perspective in their healthcare program. Oh, thank you, Tantu. So there's an effort from some organization in Myanmar to also include the cultural perspective in healthcare program, and I think it will be useful because we cannot just take people away from their cultural root. So if we came to their perspective, maybe it will be easier for them to understand what we are trying to do. Okay, so thank you, Tantuo. Nino again, nutrition and postpartum care challenge among IPs in the Philippines included dietary, colostrum avoidance, abdominal binding, okay, protection harm belief, which needs a lot of advocacy on myth and belief. Yeah, there's a lot of myth and beliefs uh, in our country, but yeah, I think there's a way to help it. Just like I know in Papua, for example, in Indonesia, there's a lot of people are giving birth in their own home, but there's problem with hygiene, and at first, the governments try to make people to give birth in their in a hospital, but it's a difficult thing to do because maybe people have their own belief why they don't want to go to the hospital, and it's still challenging still till now. But I have this discussion with some of the GPs that they said, if this is the case, then why don't we create a kind of system in which that we give some kind of kit, or also we send the GPs or other healthcare workers to the regions and to educate people on how to give birth, and so they still can give birth at home, because it's what they believe, and it's really hard for us to take them away from their root. But maybe we can educate them how to do it properly, as long as there are other things that we have prevent. So that's one of interesting topic to discuss. And there is growing awareness of the value of Mataronga Maori, and it's being incorporated into scientific research. Yeah, I think the Kapapa Maori is one of the leading researcher about indigenous knowledge, for this research. And yeah, climate change also. It connects to the contemporary lives of Maori, providing framework for understanding intergenerational relationship, environment, and cultural identity. Yeah, and I also love about the knowledge about Maori. Also, it also involves about the environment, about the planet, and it's an issue that we need to address for now. Okay, thank you, Chris. And we have a lot of people commenting. At Primary Health Center, we work in collaboration with traditional massage therapists. Oh, really? With Dukun Pijat. Okay. We gather them in a few months and give them certification to validate that they are aligned with science. Oh, that's very interesting. I think it's like traditional medicine in China. They try to have more research related to this, and then yeah, we try to organize to make a health system that support them. So that's really interesting, Britta. We don't have, yeah, in what city? Yeah, in Indonesia is very big, so yeah, maybe it it happens in one region, but it's also not happening in other region. Okay, and also I hope the guys in used to buy alcohol. Yep. Yeah, I also hope the same things or buy other thing. Okay. One more. Okay, most of you are writing in the chat, but please, if you want to say it in the class yourself, we will be happy to. I think the slogan, "It takes a whole city to raise a child," is implemented in Indonesia. Yeah, it's common to have extended family, not only your parents, but also like your uncles or the spouse from your uncles or your second, third, fourth, or yeah, fifth cousins. Yeah, the whole village will help you, and including grandparents to play active role. This collective effort helps support new parents, particularly in providing care, advice, and assistance during the early childhood. Yeah, we have a lot of support from extended family. Although it also creates some new challenges, because like there's a lot of people feeling that they need to they are demanded by this a lot of family members. Maybe they have like some certain of stigma or labels to the mothers that it makes the mother have more emotional turbulence because of the stigma. But yeah, it's also helpful if you have good families, a lot of families around. Okay, I have concern on the nutrition emergency in the displaced population. Yeah, it's quite a concern. The first 1,000 days is really important in the discussion and need to consider the emergency setting and how to promote and empower this year. Yeah. Chris, do you have anything to say? I think you're writing about Papua New Guinea.
Yeah, I just mentioned that
Yeah.
we had a big program training village birth attendants for very remote communities, and they used like things to tie off the umbilical cord and cut the cord using locally available materials, but how to sterilize them first, so that children wouldn't get infection, because there's no supply chain that was available. And this had a big impact on maternal mortality. And so very simple and relatively inexpensive. Good investment by governments in doing these sort of things. And obviously you need to provide backup support for emergencies and centres, which is problematic in some of these areas, of course, but you have to start somewhere.
Yeah, I think so. Thank you, Chris. Yeah, Papua New Guinea and West Papua are there's not only West Papua, there's now a lot of provinces in Papua now, in Indonesian part of Papua, and yeah, I think they have the same kind of culture and also the geographical challenge because there's a lot of mountains there, so it's a bit difficult to bring the mothers to hospital. But if we could educate more people to have these birthing kits, then it will help to reduce the maternal mortality.
Yeah, so I just got another comment there about using digital tools in antenatal care and support. If anybody's got an interest, it'd be interesting just to think about it during the break, because the next session will be focused on this, and it might be a little bit of opportunity to think about in your part of the world. Has anybody innovated by trying to give people information or connect them with support or something using mobile phones for trying to improve the quality of care and ultimately quality of life of children in their first 1,000 days? Be interesting to have that shared.
Yeah. Okay. Thank you, Chris. Yeah. I can add to that. One thing that I love about New Zealand is that they always have this browser alternative to their app. So because in Indonesia we have to download apps for everything when we go to the hospital. It's always about apps, but not everyone have this big space in their cell phone. So having the browser version for it really helps for everyone. So yeah, that's an addition. So we still have a few minutes, and I almost forgot that I still have one more slide. So it was question from Piers. I forgot, but there's a question related to other institution or other part other than Ministry of Health. So here in New Zealand, the Ministry of Social Development also going further with this 1,000 days program. They have this 2,000 days program, and because the kid is already 2 years old, so it's 2 until about like 5 years old, and the program is about to support positive parenting practices because it helps people to it helps Tamariki to grow into a better person and into a healthy person, and also to support development of cognitive and behavioral skills, and also still to support maternal mental health, because even though the babies grow, having toddler is also another challenge, so we still need to support mother for this issue. So this is helped by the Ministry of Social Development. So I think it's also kind of collaboration between Ministry of Health and also the Ministry of Social Development. And I also read in the chat that you mentioned in your country there's another ministries that also take parts, like the Ministry of Agriculture, if I'm not mistaken. So that's a great innovation that you do in your countries. And there's also the example here in New Zealand from the Ministry of Social Development. Okay. Oh, one more. Oh, from Jennifer. Yeah, In the Philippine trend, traditional birth attendants are not allowed to conduct delivery as all births are required to be facility-based. In response, the government initiated a pregnancy tracking program. We partnered with Trend Highlight to support this initiative by assisting mothers throughout pregnancy. Maybe it's like doula. So additionally, transportation is provided. Oh, wow. Well, it's really interesting to learn about the 1000 days program in the Philippines because you have such a complete program. Transportation is provided for women who are near their due date to ensure they reach health facilities safely. Wow, that is very great. Thank you, Jennifer. Okay, I think that's all that I can present. Thank you, everyone. Thank you, Chris, for your help, and sorry for this disruption. I give the screen back to Chris. Thank you.
Thanks, Monica. And actually, having your baby join us was quite a nice touch for this particular session. It's perfect.
Thank you.
So you're kind
Thank
of
you.
living out the teaching, and it's great to just see what other people in different countries how they've tackled some of these challenges, trying to overcome the barriers to care, to support. And I like the Philippine model is kind of working with the traditional birth attendants, but just to shift the roles to make sure that women in labour have a delivery in a safer place as possible. So it's kind of not rejecting the traditional carers, but actually trying to work with them. I think that's, again, it's like that Mataranga Māori with Western knowledge. We're trying to feed together in New Zealand to get the best of both worlds. I think it's some great examples. And some of you may have been involved in working or, sorry about the noise, leading some of these initiatives too. So thank you for sharing. We're going to have a break now for, I think the next, we're going to have a half-hour break, and then we'll come back at 3 o'clock with our session on digital and AI. So again, huge thanks to Monica. Thanks for all your sharing over the last few weeks. It's been very appreciated. You've got a nice natural way of doing it, and it's good to have a sort of insider-outsider perspective. So appreciate that. You're getting lots of hearts.
Thank you, Chris. Thank you, everyone.
And one, a big one for the special guest appearance, baby.
Yeah.
Chris, just
Okay.
to check, what time do you need them back? 4 p.m. New Zealand time?
Yes, that's right.
Okay.
Sorry. Yep.
Okay.
30 minutes.
Okay.
During the break, magically, due to our wonderful technology that's available to us, our special guest speaker, Associate Professor Chris Patton, has appeared on the screen. And Chris, welcome. It's great to have you here. We have got students from 8 of the 9 ASEAN countries represented here, and they're all people working in the health sector in various roles. And we've been working together over the last few weeks on talking about public health and how that's expressed in various ways. One of the areas that's obviously emerging as a tool in public health is the use of digital platforms, and AI, of course, is the hot issue. So we're really looking forward to seeing how you can summarize a huge field in a very short piece of time. And if there's any time at the end for a little bit of Q&A or something, that would be wonderful. But thank you very much for giving us your time and expertise, sharing your expertise, and we look forward to what you've got to share. So over to you.
Cool, thanks, Chris. Kia ora koutou. I'll just get my slides up. Sharing's not turned on, so I'll send a request to have
Suzanne will
sharing
just make you co-host, Chris. Thank you.
Okay, that should work now. Okay, share that. Go into presenter mode. Okay, so presumably you can see my slides now.
Absolutely perfect. Thanks, Chris.
Super cool. So hi everybody. So I'm Chris Payton, an associate professor at the Liggins Institute, which is a research institute at the University of Auckland. I've also got an association with Oxford University in the UK. So I was working at Oxford from 2012 before coming back to New Zealand. And so some of the things that I talk about today are from projects I did when I was at Oxford. And really, so my agenda for today really is I'm going to talk about how AI is kind of being used or on the verge of being used for improving healthcare delivery. I won't talk for too long, talk for like half an hour or so, 25 minutes, and then maybe we can have some discussions about how you're using AI in public health in your countries. So I'll start off just quite often when everyone's using AI and talking about AI, but people quite often don't know what AI is. So I'm going to try and explain what AI is, which is a bit of a difficult thing to do, but I'll give it a go. And we just got a chat message come in. I think that's okay. So explain what AI is, then I'll talk about some of my projects that have been using AI and raise some questions for you guys. Okay, so let's start off. So what is AI? So we used to call there's kind of two types of AI. One which is what we're talking about nowadays, and one which is what we always used to call AI. And so what we always used to call AI is now called good old-fashioned AI, or GoFi, and that's really expert systems, which are basically algorithms that are kind of used. And I'm sure you guys are familiar with these because they'll be used in your day-to-day work. So one example is NHS 111 online. And so this uses an algorithm called NHS Pathways, which is basically an expert system. So what happens is you get computer programmers and they talk to clinical experts, and the computer programmers say, okay, what do you want? What's your answer to this question? So if someone puts in a symptom of, abdominal pain, what should they do? Should they go to the doctor, get a call back from a nurse, or just take some paracetamol and call again in the morning? But for every kind of question, every answer, they talk to the clinical experts and they kind of manually create an algorithm with if this experts. And this was kind of how they originally thought that they would get to AI, just mapping out all of human knowledge in this way, not just in medicine, but everything. And then that's how you would get the kind of general purpose AI. And it's not like this approach failed, because we use this approach all over the place. So if you're prescribing drugs in a hospital, quite often it will use an expert system to check for drug interactions, or it might check that if a patient's allergic to a drug in their record or something like that. And it's widely used for clinical decision support and for patient triage. However, that's a bit old-fashioned now, hence the name. And what we're really talking about when we talk about AI now is machine learning. And so machine learning is about learning the relationships between things. So the classic example we use when we're teaching students about AI is predicting house prices from floor area. So the bigger the house, the more expensive it's going to be, which is fairly obvious. But really what you want to know is, if for a given floor area, what should the house price be? So what is the specific relationship? And we've all done this in, at university or at school. You plot a load of points and you draw a line of best fit. And the human intelligence can do this fairly easily. It's fairly easy to see where the line of best fit should be, but computers can't see. And you can start, but what they can do is they can start with a random line, add up how far away each point is from the line, which is called the kind of cost, and then guess again to try and minimize the cost. And it can keep going, repeating this process until the cost is minimized. And that's basically how AIs work. So if you've done some statistics, you probably know this as linear regression. And for a straight line like this, 3 points, you can actually like solve it as an equation. Like, what is the equation of the line where the average distance away is 0? And if you put this into R or start or something like that, it will solve it for you. But as the relationships get more complicated, machine learning, using an approach of guessing and then moving a bit closer and guessing again and moving a bit closer, you can map out very complex relationships, and you can't solve those equations. They're kind of non-solvable equations. But really, this approach of just guessing measuring how far away you are, and then guessing again is really how most of machine learning works. So one of the terms that's used quite a lot is so-called deep learning, and this is an approach using artificial neural nets. When we've been trying to get artificial intelligence and doing these expert systems, so computer programmers interviewing human experts to try and get all the world's knowledge, that was working for kind of specific areas, but wasn't working in order to creating a kind of general purpose artificial intelligence. So the researchers came up with this idea where they said, look, we know that there is such a thing as intelligence in the world because it's in our human brains. So why don't we try and replicate what the human brain does in a computer as a way of getting artificial intelligence? So that sounded like a good idea, and they've been trying to do that since Frank Rosenblatt's perceptron in 1957. So they actually created a physical artificial neuron using very old-fashioned computing equipment, and it actually did work. It was used for image recognition. But nowadays, everything is done with software inside of a computer. And we have many more neurons. You don't just have one neuron. You have lots of neurons, very similar to how the human brain has lots of neurons mapped together. And each of these neurons is trained in a similar way to what I was just saying about, oops, can I go backwards? Finding a relationship between two things. And training it in the same way, making a guess and then updating it. And all of the neurons in the network are all trained like this as a technique called backpropagation that enables you to find out for all the neurons how far away they are and then updating them all. And so you get quite a simple thing, which is finding a simple relationship, and then you make it much more complex by adding lots of neurons. So within a layer, you could have, say, this layer, a layer in the middle. Let me just see if I can get my laser pointer. So a layer in the middle of a neural network. Say you wanted this layer to represent a relationship that was complex. So it might be like a curve line, so not a simple line. You could have this neuron finding a little bit of the curve, this neuron finding another bit of the curve, this neuron finding another bit of the curve, this neuron finding another bit of the curve, and adding them all together, you can get a kind of curved relationship line that is then all passed on. So all of the neurons pass on their outputs to every other neuron in the next layer. And so each layer can represent different things, creating these kind of very complex mathematical relationships. So deep learning has been used widely. So we all use deep learning in our smartphones, in our computers. It's used in medicine for diagnosing radiology films. All natural languaging uses deep learning. Self-driving cars use deep learning. So when it kind of auto-corrects your position on the motorway and things. And it's because it's kind of these simple relationships, these simple kind of linear graphs, it adds up to what's essentially one big equation, but it's like a simple equation inside another simple equation, inside another simple equation, inside another simple equation, and just gets bigger and bigger and bigger. And using that kind of simple technique, you can represent very complex mathematical relationships. Okay, so that's how kind of AI works at the kind of basic level. And then what you do is you kind of scale it up. And so if the aim was with artificial neural networks is to simulate the human brain, the question is, how close are we to simulating a human brain? So if you use ChatGPT-4, so the latest version of ChatGPT is GPT-5, but we don't know very much about it. But with GPT-4, we've got these kind of estimates. So you can compare ChatGPT-4 to the human brain. So when people use ChatGPT-4, they kind of think like they're talking to another human being, and probably could pass the Turing test, which is a test of, is a computer intelligent? Can you detect that it's a computer? But let's see how far away we are from the human brain. So the human brain has got 100 billion neurons. This is Golgi's original picture of a neuron down a microscope. And you can see that you've got all of these connections all leading through to one kind of output axon. Anyway, so in the human brain, you've got 100 billion neurons. ChatGPT's artificial neural network has got 16 billion neurons. The brain, then these connections, because you've got up to 10,000 dendrites going into each neuron connecting to other neurons, you've got between 500 and a quadrillion connections in the human brain. And ChatGPT's probably only got about 1.5 trillion connections. Human brain evolved over 600 million years, whereas ChatGPT was trained in 3 to 6 months. And the human brain is then fine-tuned over a lifetime of learning. So the human connections in your brain can change and get reinforced, whereas ChatGPT, the most advanced artificial neural network, doesn't learn at all. It's just a static model, can't learn anything. It can get trained, and ChatGPT 5 is like the next version, but ChatGPT 5 doesn't learn. And also, we've got lots of humans. We've got 8 billion humans, and there's only about 2 to 3,000 GPT-4 models or even GPT-5 models online. So, just from a kind of stats point of view, we're not quite there with having the same capacity within artificial neural nets as you have with the brain, but we're getting there quite quickly. And as these things get bigger, it gets closer and closer to the capacity of the human brain. So let's just talk a bit about large language models and how they work. So these are supervised deep learning neural networks. So other AI models, which are not large language models, are all still artificial neural networks, so like image recognition models and things like that. But large language models are deep learning neural networks. They're trained to predict the next word in a sentence by sampling sentences from Wikipedia and other sources. And then that can be then used to generate answers to questions or to summarize things. So if you think of a question as you're waiting for the answer is the next word in the sentence, you can train a large language model to answer questions. So an example might be you take a sentence from Wikipedia, a dog is a kind of something, and you ask the neural network to guess the answer. When it does its first guess, like when it did the first guess about house prices, it's completely random. And then by turning the words into tokens, which are kind of numbers, you can then guess again until you get closer to the correct number. And eventually you have a neural network, very complicated, that's worked out the relationship between the beginning of sentences and the next word and can accurately predict the next word. So one thing that's happened with the kind of evolution of language, and I was trying to work out how they work, is it seemed that what I just said seems a bit nonsensical, doesn't it? So with house prices, you can imagine the equation calculating the house price and predicting a house price, but having an equation that predicts a word, and the words are all coded as numbers, so you're having an equation that adds up and multiplies up millions and millions of times until you get an answer, and then you put that back in as the word. The easiest way to do that is just to memorize all of the training data. So it's not working out what should be the next word. It's just copied and encoded into the network all of the sentences in Wikipedia and other sources. And that's called being a stochastic parrot, because when it's giving you an answer, it randomizes what word it's going to give. So it doesn't always give you the best next word. It can give you other words that are also probable. But this causes hallucinations when we try and do useful things with it. So ChatGPT can pass the medical licensing exam in the US, for example, because it's memorized all the questions and answers. But that doesn't necessarily mean it understands the questions and answers. So there's this kind of theory that these large language models are just regurgitating stuff they found off the internet. So acting in the same way as if you'd done a search on Google and found a web page and then found the line in the web page that was exactly the same as what your question was. However, and that probably is what early versions of ChatGPT were doing, and even ChatGPT 4 is probably doing that quite a lot. But there is this kind of theory that it's memorized all of the internet, and if there's an easy answer that's already memorized, it will give you that answer. But also, it's now learning about how the world works, and that's been called a world model. So as the neural networks gets even bigger, it actually learns things like what a mammal is and what a dog is, and that kind of thing. So it can actually start thinking a bit more like a human. And the idea is as the models get even bigger, it becomes more and more like a human being rather than just a regurgitator of Wikipedia. So how far along on that line we are is a bit difficult to determine, and it's quite difficult to actually evaluate in doing tests. So whether or not it's reasoning and thinking as opposed to regurgitating is still a bit of an open question. My personal feeling is that things like ChatGPT 3.5 and ChatGPT 4 base model were just regurgitating almost all the time, and that resulted in a lot of hallucinations. But ChatGPT 5 with thinking does seem to be more like this kind of artificial general intelligence, that it's more like the human brain and thinking like a human brain. So anyway, you can have a little think about that and see what you think about the future for AI in public health, and we'll have some discussions in a minute. But I'll just tell you a few projects of kind of practical uses of AI that we've been involved in. So this is a project I've been working on with a colleague in Kenya and a colleague in the UK at Oxford University. And this was to differentiate severe from non-severe pneumonia with a smartphone app. So in this project, Mauro here, he's a professor in the engineering science department. He developed some technology for monitoring newborn babies using a video camera. So the problem was that with preterm newborn babies, their skin is quite friable, so quite thin and easily damaged. And so if you put heart rate sensors and respiratory rate sensors on the chest, then when you have to change them or take them off, it can cause skin damage. So he invented this idea of using a camera and then using machine learning technology to determine from the movements and from the skin color changes, the heart rate and respiratory rate of the babies. And then, so what we've been trying to do is put it into a smartphone camera, so you can do a video of a child in a remote area of Kenya and run the algorithm, and then give information on the phone, which would be used not by a doctor or nurse, but by a volunteer healthcare worker. And then they would then, if they thought that if they had symptoms of pneumonia, like they were coughing or unwell, they could get a reading of their heart rate and their respiratory rate without having to use kind of clinical techniques. And then that enables them to make a decision about whether or not they can give them oral antibiotics or whether they need to be admitted to hospital for intravenous antibiotics. So we've been working hard on that for a few years. It's been quite a difficult project due to having to collect lots of videos and use that for comparing against existing algorithms, but still working on that. Also been working in Vietnam on the Wellcome Trust Innovation Flagship project called Vital. This is in Ho Chi Minh City, and in the Hospital for Tropical Diseases. And this was a kind of collaboration between lots of universities and all of their kind of AI experts. And they all developed different AI systems. And our team from Oxford, we looked at how you could implement these systems into the ICU. So there's lots of, I come across this all the time. So I edit a new journal about AI in healthcare for the BMJ, and we get lots of submissions with lots of interesting ideas about how you can use AI. So that, remember what I said about how AI is really just finding relationships and can find quite complicated relationships. So if you've got any source of data, you can always find like relationships. So you can always create these kind of models that predict various things. So the question shouldn't be, can I use AI to create a model to do something? It should be, what are the problems? Do we have data associated with this problem to create a good prediction model? And then if we do it, does it fit in with people's workflows? Can the hospital afford to run it? Do they have the equipment? Is there kind of a business model behind it? Do the government support these types of things? What are the consequences for patient confidentiality, patients' data? What does the regulators say about it? Is it a medical device? Do you have to do a randomized trial before you start using it? So that's all of those issues are what our team were interested in. And so we take each different innovation that they're coming up. So some of them were risk scores for patients who are being ventilated or had tetanus. Some of it was about using imaging, so looking at ultrasound imaging and to help the doctors and nurses use the ultrasound in a better way. But lots of different innovations, and we talked to the nurses, we watched how they worked, did kind of process mapping and interviews, and then examined what the kind of policies were like, and to see whether or not these kind of innovations could get implemented. We're also now working on a new project which is called a health system simulator. So this is based on a project we started in the UK. Let me turn off my laser, see if I can start this. And we developed a virtual reality training system for nurses in Kenya. This is to teach them how to do neonatal resuscitation. This does actually use quite a bit of AI, as uses a game engine to work. But we're now going to use this kind of technology of virtual reality patients and doctors and nurses to do simulations. So we put large language models in the doctors and nurses, and we get them to give them instructions about things that they have to do, and then run it as simulations to kind of see what will happen. So the kind of things that we're thinking to use this for are things like pandemic preparedness. So if you've got a 3D model of a hospital, you've set it all up so that it's working in a kind of normal way, and then you say, okay, if pandemic hits, we've got to reconfigure this ward as a respiratory ward. How do you kind of change things to do that? And also carry on using it for training and those kind of things. Okay, has this moved on? Okay, so another area that I'm quite interested in is using AI for scribing. So you've probably seen this, it's used quite widely, might even be being used right now for kind of transcribing this this call. But GPs, general practitioners, family doctors in New Zealand and in the UK and around the world are now using scribes for recording visits. So how it works is on a smartphone or on a website, the doctor will press record when the patient comes in for the consultation. It will record the whole consultation, which will then get sent out to a AI service to turn it into text. And then that text then gets sent to a large language model like ChatGPT with a prompt saying, please turn this text of this whole consultation into a short note that I can copy and paste into the medical notes. So this was quite good. This works quite well nowadays. When it first started a couple of years ago, I was saying to GPs and people not to use it because it was using those older models. And remember what I was saying a minute ago about this stochastic parrot versus actually thinking. So this really only works if the thing can actually think, really. So it only works if we are getting towards, human-like intelligence, because if you think about it, taking a transcript of a recording and turning it into a medical summary requires reasoning and thought. I mean, if a doctor was doing that themselves, they would be thinking about it. If they're just taking snippets out of the recording and putting it and like squashing it together, that's where it gets a bit unsafe, because it might miss things out if it doesn't understand it. And also the challenges around hallucination, making up facts that can go into the consultation record. So when they first came out a few years ago, they were using these older models that would hallucinate a lot of the time. But nowadays they're a bit better and they hallucinate a lot less. But there's still some questions about how safe AI scribes are. So I find it quite an interesting area for monitoring uptake of AI. Other use of large language models is as a replacement for a healthcare professional. So instead of phoning up your doctor or nurse or healthcare professional and having a consultation with them, people are starting to use ChatGPT as if it was a doctor or a nurse about their medical problems. There was a study that was done a couple of years ago where they had a forum on Reddit where doctors volunteered their time to answer questions from the public. So members of the public would post a question, medical question, and then volunteer doctors would log on, read the question, and give an answer. So some researchers said, oh, we can use this forum and the answers to test how good ChatGPT is answering questions. So we'll copy and paste the questions that the public were posting onto the forum, and then we'll compare the answers that the doctors gave to those which ChatGPT gives. And they had a panel of doctors who assessed the answers, and they were blinded. They didn't know whether it was ChatGPT or whether it was the real doctors on the forum posting. Anyway, what they concluded was ChatGPT's answers were rated significantly higher for both quality and empathy. So not only were they giving better medical advice, ChatGPT giving better medical advice, also doing it in a way that was more empathetic to the patients. So if you think about it critically, you could probably work out that the panel probably knew which, even though they were blinded, they probably knew which answers were real doctors and which answers were ChatGPT, because ChatGPT writes in a certain way and we can all recognize it quite easily, especially those of us who are marking student essays. So they probably weren't blinded, and they were probably amazed by how good it was. And also the doctors who are posting on a forum probably are not being as empathetic as they would be in a real consultation. There's also a question about what do patients want? So do patients want their healthcare professionals replaced by AI systems? And nurses have been quite vocal about saying that nursing should not be replaced by AI systems. And there was interesting protest in San Francisco last year where nurses went on strike about the use of AI in the hospital, and they said, one of their representatives said, no computer, no AI can replace the human touch. It cannot hold your loved one's hand. You can't teach a computer how to have empathy. The other question is, so we've got, are they good answers from a kind of empathy point of view, and do we want them? But the big problem we talked about is hallucinations. So there was an interesting example where some journalists, a journalist went to see a doctor who was using AI to write an article about kind of innovation, how exciting it all was. But during the interview, and this is published in the Washington Post, they tested one of the systems, and the test they said was, I've eaten a tomato and my lips are itchy. What recommendations can you give me? And the recommendation that was given by the AI system was, I'm sorry to hear about your itchy lips. Sounds like you might be having a mild allergic reaction to the tomato. AI recommends avoiding tomatoes. That sounds like good advice. Oral antihistamine, again, that's okay advice. And using a steroid topical cream. And then at that point, the doctor kind of piped up and said, oh no, we wouldn't recommend using a topical steroid cream because you don't use that on your lips because it's quite thin skin. And so that was like a obvious example of bad advice given by these types of systems just right there in front of the journalists. So you can imagine all the time over the last few years, ever since ChatGPT's come out, it's been making up all sorts of bad medical advice and confidently telling people bad medical advice. So we need to be very careful about that. And just incidentally, ChatGPT has always said it's against their terms and conditions to ask for medical advice on ChatGPT. So even though it does give medical advice, it says it's against its terms and conditions to ask it to use it in that way. The other issue about AI is about equity. So accurate AI is expensive. So when ChatGPT 5 came out, they did a comparison between GPT 5 and GPT 4 and found out that GPT 4 was hallucinating 15.8% of the time for challenging healthcare conversations, and ChatGPT 5 with thinking was only 1.6. But to access this was a little while ago. If you paid your Plus subscription, you get access to more advanced intelligence. So if you pay more money, you get less inaccurate medical advice. So if you're just using a free version of something, then you get lots of errors. And then if you pay, you get less errors, which is kind of a new challenge for equity. So it's a bit like the difference between going and seeing a top doctor and a, you know, trainee doctor. You know, the more money you pay, you get these these inequities that we've had in healthcare. So it's not necessarily reducing inequities, because people, if you pay more money, you get better AI, just like you would with a real doctor. The other thing is, although a lot of doctors are very keen on AI because it saves them time, especially with that scribing and giving them advice about what to do. So healthcare professionals have been really keen on adopting AI, but the public are less keen. So AI has actually got a bad reputation amongst the general public, which you kind of, when you work at a university or you work in a hospital, you don't necessarily think that, oh, the general public don't like AI. But if you just look at news stories about AI, they're generally negative. They're things like Elon Musk is trying to take over the world with AI robots, or, you know, Sam Altman, who's the head of ChatGPT, got fired for lying to the board. And it seems like the AI companies are run by these nefarious individuals who are trying to get hold of our data. So this kind of message has propagated, and the general public, the surveys done of the general public said they don't trust AI companies. And so if you're using AI in your healthcare practice, you need to be aware that the public may have quite strong opinions that they don't trust AI systems and they don't want their data used by AI systems. This survey from the NHS said that they would trust this is in the UK, they would trust the UK NHS with their data, so like 70% or something. Yeah, more than 70% trust the NHS with their data, but only 27% said they would trust an AI company with their data. One answer to this, this is what I think, is to put AI on your own computer and don't send the data to the AI companies. So there's lots of open source AI systems now. So these systems were trained not on the internet, but they were trained on the first AI systems that came out. So they, instead of using text from the internet to train it, they used questions and answers for ChatGPT to then train another AI model, which was almost as good as ChatGPT, and then that was open sourced. And so now there's quite a few open source models. So you can actually download these onto your own computer and run them. And Apple seem to be having this as one of their kind of strategies for AI. So the new Apple computers can run quite good AI models on the actual laptop itself. So that means that when you record a consultation with the patient, you don't have to send the recording to an AI company. You can just keep it on your own computer, and then you can use a large language model on your own computer to turn it into a summary, just the same as you would sending it over the internet. And so you can say to your patient, look, we're not sending any data anywhere, and we're not using any AI company. I'm using my own model on my computer. And so I did an experiment where I created an open source scribe, and I tested it by using consultations, like a video of a consultation that's been used for training medical students. Not sure if you can hear that or not. And this is the AI scribe running in the background, and it's listening to the consultation, listening to what the doctor is saying, what the patient's saying, and creating a transcript of that consultation. And then it kind of goes through that, doing that, and then at the end, it turns that consultation into a summary, which it then can be saved into the medical record. So just kind of showing that it's possible to do everything on device without sharing it over the internet. So what's going to happen? Everyone's asking the question, what's going to happen next? So the AI companies are not aiming at creating the current systems. They don't want to create chatbots that are useful and answer our questions in the same way that we use the internet. That's not what they're trying to do. What they're trying to do is create very intelligent systems that are more intelligent than human beings, that can replace human beings in their jobs, basically. And people have been predicting when this is going to happen for quite a long time. So in 2015, Elon Musk said there'd be self-driving cars in 2 years. Geoffrey Hinton, who's the person who invented with his PhD students deep learning on artificial neural nets, said in 2016 radiologists were going to be obsolete in 5 years. But this meme, which has been going for a couple of years, says that radiologists are still driving to work in regular cars. So there's still a shortage of radiologists. Self-driving cars are still not here, but it's very difficult to predict when these kind of things are going to happen. There's lots going on in terms of regulating AI. So the most common thing is this idea of using AI as a medical device. So you can regulate AI as in the same way that you would a pacemaker or something like that. So if it's used in a critical way in healthcare, so important decisions are being made based on the AI, then you probably should do trials of seeing how accurate it is before you use it. And governments are starting to adopt that around the world as the kind of regulatory framework for AI. Yeah, so that's all I want to say. So maybe we can have a bit of a discussion. I'll stop sharing. We can have a bit of a discussion about how you are using AI, what you're using it for, whether you've used it in any similar ways to the ways that I was talking about then, or different ways, or any questions people have about AI and what they think about AI. So maybe I'll open it up to the floor.
Yep. Thanks, Chris. That was great. And yeah, so maybe either if you want to unmute and ask your question, or you can pop a question into the chat and we'll keep an eye on the chat. So anybody with any experience, no question is a bad question here. So let's share our experiences and understanding.
You
We
can
have
also
got some
just
students
share
from
your...
Vietnam here, by the way. Sorry, Chris.
Oh, great. Oh,
Yeah.
awesome.
So
You
some
can
of
also,
them may...
yeah, just state your opinions about AI as well.
Yeah.
It doesn't need to be a question.
Mm.
Say what you think is going to happen in the future.
Okay, so here's a chat comment. It's difficult to decipher from correct data or not, or facts, other facts from a legitimate source. So is that validation issue, verification issue with AI?
Yeah.
It's kind of a statement or...
So difficult to do, AI chatbot, Google Gemini, but it's basic mental health support. That's quite interesting. So who's posted that one? Do you want to say what you were saying?
Phone from Myanmar.
Oh, I'm sorry, I'm not clear the question.
Do you want to just share what your about your pilot initiative, Phone, after the
Yeah.
earthquake?
Yeah, after the earthquake, we developed a chatbot in Telegram, which is a commonly used communication platform in Myanmar. And we integrate a Telegram chatbot in Telegram using the Google Gemini 2.5 Flash LLM. Singaporean developer team help us to develop that bot. The main focus is to support the basic mental health care for the earthquake survivors and caregivers. The main reason why we use the Google Gemini 2.5 is the language capability of Google for the Burmese language because the Google has more fluent in replying the users in Burmese than other models. So we use that model, and it is very useful so far in the earthquake affected area. We are still using that chatbot. Yeah.
Oh, very good. Yeah, excellent.
Can I ask, have you had any issues with clinicians or patients or people complaining about the responses?
Yes, the main challenge is to the linkage because we don't have a match as this is the pilot initiated and we don't have match support for next steps or care after the basic support, and patients in the aqua-affected zones are more needed than we estimated, and they demand so much mental health care and so much physical support in their daily lives, and we cannot support that much in this pilot initiative. So that was the main challenge. Another thing was the referral linkage to the higher level service provider like psychiatrist or psychologist. So we don't have that much personnel here, so we have very difficulties to link the users with the service provider. Yeah, but we have a telehealth team which has a medical doctor in the team and who completed the basic mental health care support training, and he is managing to engage with the users who raised from the chatbot. He is providing a basic mental health care over the telehealth platform. Yeah.
So does the Google Gemini provide advice, or is it just for translating the questions and directing the users to, real people?
So far my understanding, the developer didn't use the Gemini LLM to reply to have the query and to reply by the reasoning directly with the user. Yeah, we so far my understanding is they give prompted direction for some inquiries like to reply smoothly and promise to reply to focus on the basic healthcare and not to focus on so many other queries. Yeah, like.
Okay, interesting. So got another question. So can you recommend some ways to ask questions prompt to increase the search efficiency when using ChatGPT? So I think the main thing that I found is which version you're using. So prior to GPT-5 with thinking, I found it hallucinated too much and was not useful. So I would try and do lots of tests and try lots of different scenarios, and it would always end up with giving me some kind of incorrect information. And I see that a lot with students as well. So people using like the normal version, if they're trying to get their essays written by it, it's pretty obvious because it keeps making things up and it's incorrect and it just is not thinking like a human really. Whereas if you subscribe and pay your money and you're on the latest version, GPT-5 with thinking, I think it's just about getting there now that it is not making lots of errors all the time. So it's worthwhile actually using it. So all the previous versions, I've tried them lots and done lots of experiments. And I've always found in the end it's just not something I'd ever recommend anyone use for anything. But now it's getting to the point where it's actually useful, and I think in the future it will get even more useful. So one recommendation is to pay the money, which is currently in New Zealand, I think it's like $40 a month, something like that, which is quite a lot of money. But if you use the free version, then it won't be anywhere near as good. If you want it to be more efficient, you do have to kind of get used to this idea of prompting properly. So writing your questions in a way that's going to get you the answers. So asking it to answer in a certain way, or to use the research evidence. So for example, telling it not just to use the base model. So when the base model is trained, it's got lots of facts and information within the actual model itself, but also now it uses what's called agents. So it will send agents off to the internet to look at web pages, and it's not really clear how many agents it's doing it. It seems to be that it'll send off multiple versions of GPT-5 to the internet to go and read web pages. So if you specifically instruct it to do that, then it can find more information. So say you wanted to look at a research article and you wanted more information, you could say to it, read the research article, but also follow all the references. Tell me what data are in the references, and it will bring all that back and summarize it, and is pretty good at doing that. So yeah, so you do have to kind of learn how to get the best out of it, as well as using the latest model. So and further, how can ChatGPT be used in healthcare safely and public health? So I don't think it's very safe for patients to use large language models for healthcare advice at the moment. I think the best use of it in healthcare is for and this is this caveating this saying only GPT-5 with thinking, so only the very latest version. Not GPT-4, because GPT-4 is not useful, I don't think. But GPT-5 with thinking can be useful for trying to find literature on a topic that you're interested in and summarizing it. So if you're looking after a patient, say, you could use ChatGPT-5 with thinking to say, okay, what are the latest research studies about this particular patient, and that kind of thing. And if you check that it's correct in what it's saying, so follow the links, it gives you links to all the sources it's using, and you check that it's correct. That can be quite a useful way of finding studies about things that you didn't previously know about, especially if it's quite a complex new thing. But you have to be very careful, be aware that it still does hallucinate, still does make up things. So it might make up that there's a study that said something like there's this is a new drug you can use or something like that, that it's just completely made up out of thin air. So you always have to be very careful checking it. But it's now, if you use it a bit like you would previously use Google, it can be a lot faster than using Google and give you a lot more information. It can search the web for you and bring data back to you. You just have to be quite careful in how you're using it. But never use it just asking it a question and just taking the answer and then acting on it, because there's always a danger that it's made something up that was completely fabricated and incorrect. And patients should never, you should never tell your patients to use ChatGPT for health advice. It's not good enough at the moment. So for the Vietnam project, the data were trained on data that were collected within the hospital. And some of that was about previous research studies that have been going on for quite a few years. And some of it was being trained on data like signals from PPG sensors, pulse oximeters, and that ultrasound data as well. So because it was embedded within this research unit, there was research data plus hospital data. And then the other thing we were trying to do was use data from the electronic medical record system. So we did quite a lot of investigation about how we could pull data out of the electronic medical record system for using for AI. The data in the electronic medical record system was not very accurate though. So quite often, so for example, if you're using like blood pressure readings from an electronic medical record, you have to be aware that sometimes the stuff that goes into the electronic medical record is made up by the healthcare professionals. So then if it's just being used for documentation and not being used for care, it might be inaccurate in the medical record. So you have to be very careful about using electronic medical record data for training AI. You can't assume that the data is a fair representation. Research data is normally a bit better because it's been thought about what you're collecting for the research purposes, and sensor data is even better because raw sensor data is difficult to argue. It might be biased in a certain way, but not completely fabricated or really missing or that kind of thing. It's quite a long question here.
Quite a long thing here from Indonesia, yeah. Aya?
That sounds interesting. Lots of projects going on. Regulations evolving. Ethical oversight.
Be screening.
We are doing a project about stunting matter based on AI right now. still on review about that. Hope still we're doing it good, and we already have innovations from another university, Gajah Mada University, about tuberculosis based on AI screening for tuberculosis, TB screening.
Very good. Yeah, so I think the laws are not keeping up with AI is one of the big problems. So where medical data should be sent and what classified as a medical device, all of these problems are not keeping up. So people don't really know if they're allowed to use it or not. It's a problem we had in New Zealand for the last couple of years. So everyone wanted to use AI scribes in the hospitals, and then there wasn't really did they know if the AI scribe made something up, who was going to be liable? Was it going to be the doctor? And how much consent do they need to get from the patients about where the data is sent and things like that? And so there was a lot of confusion. So the healthcare system just said, don't use AI in the hospitals. Whereas then the GPs, because they were outside of that, they could do it, they could use it. So all the GPs have been using it for a lot longer than the people within the hospitals. Now the hospitals have assessed some systems and said people can use certain systems, but it's still not kind of been sorted out legally, really. And there should be like medical device type regulation within the country about how things should be used, and what evidence is needed about effectiveness. And also confidentiality of patient data. So it is quite tricky for healthcare professionals to work out what they're allowed to do with AI legally, really. Super. So I think we might be out of questions, but send me an email if you want to, and keep in touch, or connect with me on LinkedIn as well. I'm quite happy to do that. I post quite a lot on LinkedIn about various AI topics, or I used to anyway. Haven't been doing it for a few months, but hopefully get back into doing that a bit. So what's going on in terms of what the FDA and people are saying about regulating AI and things like that. Yeah, so stay in touch.
Thank you, Chris. That was fantastic and great responses to excellent questions and comments from class. Just with your LinkedIn site, is that, can you post that on the chat, or we can pop that up?
Yeah, I'll put a link to me.
Yeah, that'd be great. Thank you. Yeah, so Chris is inviting you. There we go. It's just popped up in the chat. Thank you very much. So connect with him on LinkedIn. I think it's a good way to do that securely and safely. And a huge round of applause from everybody here for what is a very insightful and informative and helpful presentation. Really appreciate you sharing your expertise with us. I think we're all trying to grapple with how we use these tools in the right way and brave new world of AI. It's transforming everything, but maybe not as fast as some people said it would be.
Super. Thanks, Chris. Thanks, everyone.
Thank you. Thank you very much. Okay. Ka kite. All right. Well, there was a lot of food for thought there today from both presentations. The AI one, I think there's more to read on the reading of resources, and keep following. If you're on LinkedIn, follow Chris and see what he posts, because he's always got he's very good at bringing things down to a very common sense, clear phrase, because there's so much hype about AI, I think. Even without AI, we've still got simple digital tools like messaging, which have been shown to be effective in lots of areas that can still be used. Even if people don't have smartphones, they can have basic communication. So, and it's been used for malaria management training, for emergency maternal health crisis management, for smoking cessation, for mental health, physical activity promotion, and it's just SMS messaging. There's good evidence from well-conducted research studies to show that in a range of settings, both in high and middle and low income countries. So we need to think about affordable, accessible solutions that have been shown to be safe and effective, and can reach lots of people, particularly more vulnerable populations. And And then the AI is now kind of the icing on the cake and promises to power up a lot of these things. But of course, there's a cost with AI. All the servers that support the AI are very energy intensive and also use a lot of water. So whenever we go and ask a question on ChatGPT, just think about how much energy and water consumption we're contributing to. So there's always a yin with the yang, the cost maybe with the benefit. So okay, well, I hope that's been a really interesting session for you today. Continue to engage with the material on Canvas, and I look forward to joining you tomorrow. We're going to talk about research monitoring and evaluation and behavior change, which are both very important areas to engage with in our work as we work with our communities and societies. And we see how they all fit together. And I am going to now close our session just a few minutes early with a closing karakia. And the weather here in Auckland is deteriorating, apparently. We're going to have thunderstorms and electrical storm activities tonight. So we have to get out of the way of the lightning. Okay, I'm just finding the right one here. All right. Okay, so here's our karakia. Unuhia, unuhia, unuhia ki te uru tapu nui. Kia wātea, kia māma, te nākau, te tinana, te waro e rara takatu, koe rā e rongo whakaria, ake kia runga, kia tina hui tai kie.
Thank you.
Okay, thank you, everybody. I hope that's been a really interesting session today, and we look forward to some more conversations with you tomorrow.
See you tomorrow.
Yes,
Thanks,
See you
everybody.
tomorrow.
Thank you, everyone.
Thank you.
See you tomorrow.
Thank you so much.
Thank you
See you
so much.
tomorrow.
Thank you so much.
Very interesting materials today.
Good, good.
Wow.